midpoint of my putting woes.
Right now, because it's like summer, all of us are on. Great.
Somebody use it.
First, we're going to play IR, like the use like what
I haven't, that's the only thing I haven't been for. Over there.
I know we were. Well, how about you? I think we're like.
You got yours. You got yours. You went. So that's what
I do it on
yeah, something happens.
You didn't team up, please, with that. Where's your chat, man? This weekend. No, it's just working. Yeah, and it's down. You might be a little behind. So I was going to get it actually usually Hey, I'm not going to do anything different. I'm just going to yeah, a little bit. Actually, now the ladder. I think you tarmac and it's like general riser. You don't write down. I wouldn't say if you rest in peace, just go on. Her son and
make sure he's okay.
Thanks.
That's great. Yeah. Read it out loud while you're here.
One day.
Morning, everyone. I guess it's 8:12, so we'll get going. So it is my distinct pleasure and honor to introduce our grand round speaker today, Paul Baker. Dr. Baker is our MIS Bariatrics Fellow this year. He joins us from, well, I guess you were at University of Miami for medical school. Then went to Mount Sinai in Miami Beach for residency, and that's where you're returning for after fellowship as staff there. So I saw Dr. Baker's CV, very impressive, lots of accomplishments, but really what strikes most is his dedication to resident education and training, as evidenced by being the recipient of the Fellow Teaching Award at UVA as well. So that being said, his talk today is about the landscape of obesity, medicine, and bariatric surgery.
Thank you. the introduction, Dr. Shin. For those of you with whom I haven't had the pleasure of working yet, I'm Paul. I'm this year's MIS Bariatrics Fellow. And today I'd like to talk a little bit about what is, a landscape that seems to be constantly shifting under our feet, and hopefully how it's pertinent to everyone's practice, not just that of general and bariatric surgeons. So to set the framework for what we'll discuss today, unfortunately, we do have to cover the bland epidemiology aspect of the topic first, and then I'll go over everything that we have available to treat obesity. We'll spend the bulk of our time today talking about the emerging role and implications of this landslide of new anti-obesity medications. We'll talk a little bit about some of the interventional things that we have to offer from our perspective as surgeons, and perhaps most importantly, talk about where this leaves us as both surgeons and healthcare providers in what's ultimately a longitudinal approach to a very difficult problem that is only getting worse. And hopefully at various points throughout the talk, whether you're a general surgeon or otherwise, there will be some pertinent aspects that you can carry with you forward to your practice. So where do we stand today? It's pretty bleak, as I'm sure most of you know. 4 in 10 American adults have obesity as defined by a BMI of greater than 30. 1 in 10 have severe obesity as defined by a BMI of greater than 40. Perhaps more striking to me, at least, is the fact that over 70% of US adults are overweight or obese, which is just a BMI of greater than 25. The subject of most productive years of life are perhaps up for debate, but I would argue that most productive members of our society are disproportionately afflicted by obesity. Those aged between 40 and 60 are obese at about 50% clip. Unsurprisingly, there is a disparity with respect to educational attainment, and folks who have had the benefit of more education are still obese to a rate of 30%, but it's much lower than those who do not have a second or post-secondary education. So it's not so much that the prevalence of obesity is exploding. It's been pretty stable for about a decade now, but the more alarming factor and something that's very pertinent to surgical practice is that the severity of obesity continues to worsen. The proportion of people suffering from severe obesity is getting higher and higher every year. This is the traditional heat map, which unsurprisingly shows that the southeastern United States and the Midwest are disproportionately affected by obesity. As a native Tennessean, I've always depended on Mississippi and Louisiana to make us look a little bit better. But unfortunately, we're right there with them. And then I may be from Tennessee, but my folks are all from Kentucky, and they were perhaps wise enough not to submit their data. I think they would be right there with Virginia. Now, Virginia, despite being, well, personally, I don't think Virginia counts as the South, but most people say that it is. It's doing pretty well, but still, even in Virginia, where there are some metropolitan areas where the educational attainment is higher, the prevalence of obesity is greater than 30% across the state. So that 30% prevalence ends up being about 3 million adults in the state of Virginia suffering from obesity. And you'll see a slightly different heat map here, and that just breaks down the health status by county. And again, you'll see that southwestern part of the state is disproportionately affected, and it comes as no surprise that's in our Appalachian region. It is sandwiched between my homelands of Kentucky and Tennessee, and it's a very serious problem in that part of the state. I think while this may seem glaringly obvious, the important takeaway is that obesity has now surpassed smoking as the leading modifiable risk factor for early mortality. And as a surgeon, regardless of your expertise or specialty, I would argue that this is the most common chronic disease that you will encounter, perhaps aside from hypertension. So why should you care, especially if you're not a general or bariatric surgeon? And the answer is most of your patients are obese. It obviously makes all surgical interventions more technically difficult and treacherous, and creates circumstances for a higher likelihood of adverse outcomes. And as we get into a little bit later on in the talk, you cannot ignore the explosion of GLP-1 prescription. And even if you would prefer never to operate on a patient who's obese and you're constantly telling folks that they need to rehabilitate or any kind of intervention, you will be asked in clinic by these folks who are obese whether or not there's anything they can or should do, if they should be taking some of these medications, and if they should do something, what should they do, because the options are becoming dizzying with each passing day. So even if you're not providing metabolic or bariatric care, I think it's important that we all understand the full treatment landscape and be abreast of its evolution. So we'll talk now a little bit about the range of therapies that are available. We'll go in order of least to most invasive. And accordingly, it goes in order of least to most effective as well. You cannot talk about obesity treatment without talking about lifestyle intervention. Oh, before I dive into that, just globally speaking, how effective is each category? Lifestyle changes alone, based on who you ask and the data to which you refer, can yield up to 10% weight loss at a year. Unfortunately, there is a lot of relapse. We'll get into that a little bit. Medications, this number is perhaps already outdated with the changes that have happened in the last year, but some randomized controlled trials will show weight loss of up to 20% of total body weight, and there are some that are doing more than that now. Endoscopic therapies are still largely considered adjunctive, but there are some index procedures, and depending on who you ask, these can yield up to 20% total body weight loss. And then surgical interventions are, of course, the most effective and most durable, but not without their own shortcomings. So lifestyle modification is obviously the least sexy and the hardest, but it's an important first step for every patient struggling with obesity. And the cornerstone of lifestyle modification is basically therapy. It's called intensive behavioral therapy, but it's essentially cognitive behavioral therapy. And to no one's surprise, the more frequently patients are engaged with this, and the more components are involved with this, the more successful they are. We have found that lifestyle modifications are most successful when these folks have a chance to speak with a nutritionist. They're encouraged to develop good habits with physical activity, and they're able to talk, whether it is on an individual basis with a therapist or in a group setting. Unsurprisingly, weight regain is very common after 3 to 5 years, and this essentially requires constant, sustained follow-up or adjunctive therapies, which is the direction that we're moving. Unsurprisingly, the cost is the least by far, is overwhelmingly covered by insurance and Medicare and Medicaid, and this is something that can be successfully managed largely by primary care physicians, which makes it an appealing option, and they can also manage a multitude of patients at once, which collectively drops the cost, and there are also now, thanks to technological advancements, a lot of ways that people can do this in a group setting or even virtually that does show some promise. I think the reason that the cost for quality adjusted life year there is less than 10,000 doesn't sound all that great. I think it's because essentially the total number of quality adjusted life years is rarely that high, usually on the order of 1 to 3 quality adjusted life years. So this kind of gets me to the meat and potatoes of what we'll talk about today, just because there is so much information, and it will be pertinent to everyone's practice. I think if there's anything you can say before diving into this, it's that every generation has had a miracle weight loss drug. And the United States is in a pretty unique circumstance in that we have this remarkably, unbridled and aggressive direct-to-market advertising. So that people are exposed to these things by the pharmaceutical companies, often without little to any counseling from their healthcare providers. So you can see here, some of them are pretty absurd. The earliest ones, amphetamine is pretty effective as a weight loss agent. These folks don't eat. But as you all understand, there are a bevy of unsavory side effects. Dexatrim had a minute there in the 80s and was very heavily marketed. And then, perhaps this is the most appropriate place for my opinions, but I'm personally very disappointed in Serena Williams. I've never been a big fan of her on-court persona or public persona, but I think that she is the single most dominant athlete that's ever lived across all sports. If you look at her run of Grand Slam championships, and I'm happy to debate that with anyone. And again, I say that I'm not a big fan of hers personally, but she is now endorsing these telehealth GLP-1 receptor agonist drug subscription services, which are fraught with their own shortcomings, and we'll discuss a little bit later. So this is nothing new. People have been trying drugs to lose weight for a long time. I mentioned amphetamine. It was probably the first widely documented medication used. It was initially off-label for appetite suppressive effects. Obviously, this was deemed unsafe shortly thereafter. I think a pretty watershed moment was the approval of fenfluramine in the 70s. It's essentially amphetamine derivative, but it was withdrawn from the market in 1997 after fen-phen, which is a combination of fenfluramine and phentermine, which is still on the market, was linked to very severe valvular heart disease and pulmonary hypertension. And when that got taken off the market, there was a little bit of a lull. Innovation stalled because there was, for good reason, heightened regulatory scrutiny, and there were very few new approvals until the early 2010s. Jumping this off was the approval of lorcaserin, marketed as Belviq, which is it's like a serotonergic drug that helps suppress appetite centrally. And this has since been withdrawn from the market 6 years ago. And then venturamine and topiramate combination, marketed as Kismia, and bupropion naltrexone, with which you might be familiar from its usage for depression and opioid addiction, has also been approved for weight loss. And then now you could probably devote a line to every month with everything new that's happening. But things really got heating up in 2021 when semaglutide was approved by the FDA. First as Ozempic for type 2 diabetes, but then subsequently as Wegovy for weight loss. And then shortly thereafter, tirzepatide, which is perhaps the workhorse now that you'll encounter clinically, initially marketed as, again, Zepbound for type 2 diabetes and subsequently Mounjaro for weight loss. Or excuse me, that's backwards. Mounjaro was for type 2 diabetes and the Zepbound is for weight loss. The reason this was a big new era was because, and I'll get into the effectiveness of these drugs a little bit later, this is the first time there was a total body weight loss that approached a meaningful level. The STEP and SURMOUNT trial showed that these drugs alone, when compared to placebo and active lifestyle, could result in up to 20% total body weight loss. So it feels like just yesterday you probably started seeing the advertisements now with Charles Barkley for the oral GLP-1s. The FDA approved oral Wegovy and orforglipron, and that's the last time I'll say that in this presentation, marketed as Foundayo. And the new wave is now these multiple mechanistic medications that are not yet approved but are coming down the pipeline, most notable of which is retatrutide. Eli Lilly is working on this. It's currently in phase 3 trials. Its mechanism is glucagon-like peptide 1 agonism, gastrointestinal peptide receptor agonism, and glucagon agonism. This is not yet approved, but the preliminary study results are promising. It seems to be very effective, and it will likely be approved later this, if not later this year, in early 2027. The same goes for a drug called CagriSema. You can expect to see this one. It's a combination of semaglutide and amylin analog, which is essentially a GLP-1 plus, again, a centrally acting appetite suppressant. So why are we seeing all this now, just in the last couple of years? And like the answer to many questions in life, it's money. The industry is highly incentivized to create these drugs. If you could be tempted into manufacturing something and half the country would be a lifelong customer, you would be motivated as well. And the federal government, who's the biggest payer in our healthcare system, is also highly motivated, as obesity-related medical costs exceeded $170 billion per year in 2023, and that stands to only continue to get worse. The big names in this action are Novo Nordisk, Eli Lilly, Pfizer, Amgen. I didn't mention this at the beginning, but I have no disclosures. I think I've got like 10 shares of Merck, and I'm not sure what they're doing in the game right now. But the bottom line is this market is huge. It's not going anywhere, and it's only going to get bigger. 2023, it was estimated that this market was $6 billion, and Morgan Stanley is estimating by 2030 it's going to be up to $50 billion. So I apologize. These two slides are pretty busy, but I think the simplest way to get past all of the obnoxiously convoluted names is just to kind of look at them side by side. At the end of the day, these pharmaceutical companies are focusing largely on the same mechanisms. But the GLP-1 receptor agonists are semaglutide, liraglutide, and tirzepatide. The names that you know are Ozempic, Wegovy, Mounjaro, and Zepbound. The mechanism of action is multifactorial, and I'll get into that in a little bit more granular detail in a couple slides. But these, depending on the trial that you refer to with a specific drug, result in a total body weight loss of up to about 20%. And these initial formulations were all weekly injectables, as they are pretty large peptide molecules, and they're easy to deliver in that fashion. Perhaps most important to our discussion is the cost, because that's unfortunately a big factor in how we make decisions on how to treat these patients. All of these run at $1,000 or a little bit more dollars per month. The side effects, I would argue, are the intended effects. They essentially cause delayed gastric emptying and gastroparesis. So these folks will almost invariably experience some degree of nausea, vomiting, constipation. And then a lot of them will also run into issues with pancreatitis and development of gallstones and the sequelae of that. The mechanisms of which are largely hypothesized, but probably has a lot to do with the global slowing of everything digestive, the effects on cholecystokinin, and the downstream effects of that. I included some of the legacy drugs at the bottom just so you can see what they do, how much they cost, and some of their downsides. Phentermine is something that you'll still see pretty frequently because it's cheap, it's widely available, and it's not unreasonably effective. You'll see folks on this if they're trying to lose a few pounds before an elective hernia repair or getting a knee replaced. It can account for up to 10% total body weight loss. It's a pill taken daily, and it's cheap, $100 to $200 a month. The side effects are consummate with what you would expect from any sympathomimetic. Bupropion and naltrexone you're probably more familiar with, both on their own and in combination for treatment of major depressive disorder and opioid addiction. The mechanism is norepinephrine selective reuptake inhibition. And in that sense, it's not dissimilar from phentermine. It's not quite as effective. It's also a pill. It's also cheap. And the side effects are well documented from its use in the psychiatric population. Orlistat I include really just kind of as a reminder of how far we've come. And I'm personally of the belief that anything that we are currently doing in medicine will be looked back upon in 50 years and seen largely as barbaric, probably. Fortunately, that's the nature of progress. But this is kind of a barbaric medication in the sense that it just inhibits pancreatic lipase. Folks have a meal, they take the pill with it, they can't absorb fat, and then they experience some very unsavory, loose, oily stools. But hey, it's cheap. It's the cheapest one here. So this busy slide just shows the ones that are kind of on the horizon and the ones that were approved just this year. The oral Wegovy, the Foundayo, and the retatrutide. They're all firmly rooted in the GLP-1 research. Retatrutide, again, has triple mechanism action. And you'll notice the common trend with all of their phase 3 randomized controlled trials is that they named them very optimistic and upbeat. So the Triumph trial for retatrutide is preliminarily showing up to 24% total body weight loss, which is the best of any medication and is on par with a lot of surgical interventions. It is an injection that's still taken weekly, and unsurprisingly, the cost of both this and CagriSema are not yet available. I'm sure that will be parsed out based on payers and a variety of factors that are well above my pay grade. The catch with the retatrutide is that it is very potent, and for that reason, it has greater efficacy, but it has a lot of the same unsavory downsides of the GLP-1s with lower tolerability at higher doses. So patient selection is going to be critical as these drugs become more and more targeted and potent. The CagriSema is also investigational, also anticipated to be approved either later this year or early next year. Their redefined trial is showing similar weight loss profile to the retatrutide. And the only difference there is that it has this amylin analog, which essentially modulates central satiety signaling after a meal. So I'm not remarkably well versed in the basic science of how these works, but these drugs are pretty well understood and they work in a variety of ways. So first off, GLP-1 is an incretin hormone. It's released from the L cells in the small bowel and works in paracrine fashion to do a variety of things in the GI tract. It enhances glucose-dependent insulin secretion from the pancreas. It helps suppress glucagon, which in turn helps the liver to maintain lower fasting glucose levels. I think perhaps the most potent effect is its effect on gastric emptying, which leads to earlier satiety and folks eat less when they're on these medications. And it also works on the hypothalamic appetite centers, which decreases hunger signals and promotes satiety. And in summary, the weight loss effect of these drugs is really more from reduced caloric intake, not because these folks are increasing their energy expenditure from the modulation of their metabolism. Fortunately, these medications are pretty darn safe. There's a minimal risk of hypoglycemia when they're used without insulin or sulfonylureas. So now that we're through the drugs, I think I would like to think that this part of the talk is perhaps the most applicable to everyone in the room, regardless of surgical subspecialty. But the most important question that we have still yet to really hash out with the support of high quality data is how do we treat patients who are on these drugs who need surgery? This has been a constantly evolving topic. And because of the delayed gastric emptying, there is an understandable increased risk of aspiration during anesthesia. So it's something of which we need to be acutely cognizant when taking patients for elective procedures. So in 2023, the American Society for Anesthesiologists recommended for folks on daily formulations to stop at the day of surgery, and for folks on the weekly injectable formulations to hold it for a full week or two before. And then they added as an extra tidbit, consider involving your endocrinology colleagues if you anticipate difficulty controlling blood sugars in the perioperative period while they're off these medications. Now, with a little bit of whiplash, a multi-society guidance was published shortly thereafter in December of 2024 with the input of a variety of professional societies. Those include the American Gastroenterological Association, ASMBS, the American Society of Anesthesiologists, they weighted on this one, the International Society of Perioperative Care of Patients with Obesity, and SAGES. Perhaps you'll notice in the tiny print there, it looks like it's a little blurry on the main screen. The second author is our very own Dr. Wang, which I actually didn't know until I was looking over this beforehand. One of our gastroenterologists has helped me out with a few tight spots on EGS call. So if you have any questions about the evolution of this data, I'm sure he would be an excellent resource. But in short, they basically said, do away with that recommendation to hold things. And it needs to be, like many things in medicine, a case-by-case shared decision-making process that weighs the metabolic benefit of these medications versus the perioperative risk of the delayed gastric emptying. Critical to that assessment is the pre-procedure assessment of whether or not these patients are potentially going to aspirate. So fortunately, this is pretty straightforward. Folks who are at increased risk of worsening delayed gastric emptying are those who are in the dose escalation phase of these injectable formulations, folks who are on higher doses for longer periods of time, people who are on the weekly formulations, in contrast with those on the daily formulations, and then understandably, people who are actively experiencing symptoms of gastroparesis or delayed gastric emptying, anyone who might be complaining of nausea, vomiting, dyspepsia, or constipation. Important to take into consideration is whether there are any confounding medical factors or things that could compound the effect of these medications, like global dysmotility disorders or Parkinson's. And all of these need to be assessed early in the preoperative phase to modify your plans. So, in short, if you don't identify the patient at high risk for aspiration, the recommendation is to continue with these medications, both the daily and weekly formulations. But if you identify any of those high risk factors, the prevailing sentiment is that these folks should be on a full liquid diet for a full 24 hours preoperatively, not unlike what we do with colonoscopies or bariatric cases. They advocate for the use of point of care ultrasound if resources allow to assess whether or not there are any contents in the stomach. This is obviously a very limited modality in people who are obese, but it's something that can give some peace of mind. And then if there is any concern, they recommend rapid sequence intubation with or without upright intubation if you're concerned about the potential aspiration of the gastric contents. The key moving forward will be to develop protocols. They're just institution-wide so that we can have a unified approach to this issue. The goal of the multi-society recommendation was essentially to prevent cancellation of procedures while maintaining patient safety. And they say all of this with the caveat that this is, of course, a rapidly evolving field, and as more potent and more targeted medications like the triple agonist therapy, these recommendations will probably continue to evolve, and it's important to stay abreast of those changes. So, in summary, if you're going to take someone to the operating room and they're on all these medications, what do? There's been a largely held misconception that they all need to be stopped. That has since been reversed. Most people can continue therapy. We always thought that these weekly formulations required at least a week-long hold. That is not recommended routinely unless they're increased risk for aspiration. And it used to be thought that if they have GI symptoms, that would reliably retain gastric contents, but we now know that that's really just a risk stratifier, but it's far from perfect. And even if patients do hold these medications and you do keep them off a liquid diet and they aren't having any symptoms, the risk for aspiration is still there. So you need to approach them all with caution. So this slide is just a little bit of an aside. Is a natural subsequent question when you're talking about perioperative care of these patients is, are there any other issues that might arise with these GLP-1 medications? And the short answer is not really. Based on the limited data that we have, it turns out they're pretty effective drugs and pretty safe. This study did identify the increased risk of gastric contents, but overall in the perioperative period, they did assess perioperative hypo or hypoglycemia, any need for post-op inotropic support, post-op nausea and vomiting, AFib, 30-day mortality. Unfortunately, there was no change. So the takeaway message is that these drugs are safe and it shouldn't be a reason to prolong surgery. So this takes us a little bit into some of the social and economic dynamics of these medications. First of all, who's prescribing them? And the answer is a lot of folks, and it will continue to be a lot of folks and even more. Historically, it's been obesity medicine specialists, more and more now PCPs, endocrinologists because of the initial indication for type 2 diabetes. And in a lot of cases, bariatric surgeons prescribe these as well. Perhaps most troublesome is the explosive growth of telehealth platforms like Row, HIMSS, Calibrate. And again, I think this is in line with the cultural expectation in the United States that there's a magic pill that will fix your problems, and we have a lack of regulatory oversight to prevent this type of aggressive direct-to-consumer marketing that I think, regardless of how you feel, has plagued our healthcare system. So what are some of my holdups with these telehealth platforms? I think a lot of people share these feelings. These are obviously designed to extract as much wealth as possible. To that end, there is absolutely no longitudinal follow-up of these services. They're subscription models. They don't take into account the whole patient. The initial screenings that folks perform to get these medications are extremely limited. They rely almost entirely on subjectively reported data from the patients without a physical exam or any other kind of objective workup. Patients don't necessarily think of it as a medication in the traditional sense, like when they go to get a statin from their primary care physician. So they're much less likely to tell these telehealth platforms that they're on X, Y, and Z other medications that could potentially have serious interactions. And then when folks are getting this fragmented care from a telehealth person over their phone and then a surgeon in the office, there is rarely, if ever, any crosstalk between these prescribers and surgical teams. I've already complained perhaps too much about the aggressive marketing and consumer misinformation. And again, these platforms are heavily incentivized just to prescribe quickly. And because of the rapid growth, it is understandably completely outpaced any type of regulatory oversight. And there could be an entirely different TED talk on the data privacy and ethical concerns. So what do we have to expect with pharmacologic weight loss in the future? I think more and more, and we're already beginning to see this with Serena Williams, for example. This is no longer something that folks are getting on when it's deemed a last resort. Whether severely obese, folks who are approaching normal BMI are going out of their way to get on these medications. And in some cases, we see it as effective and potentially useful as a first-line adjunct, managing overweight folks and trying to prevent the onset of certain comorbidities and metabolic syndrome. You will continue to see expanded indications as pharmaceutical companies are funding more and more trials to expand the potential uses of these medications. And I think one of the most important points of today's talk is that these will be used in adjunct with surgical procedures. What they may delay or reduce the need for bariatric surgery. A lot of folks will probably hope to avoid bariatric surgery entirely on these medications. But I think more realistically, we'll probably see this as an adjunctive therapy in addition to surgery, both before and after. So as these become more and more common, primary care physicians will become more and more comfortable prescribing them. So you can expect to see these managed less and less by subspecialists like obesity, boarded obesity medicine doctors or bariatric surgeons. And you can expect to see primary care physicians managing their entire clinics with folks on these medications. Obviously, there are new drugs coming down the pipeline. We've already touched on the triple agonist therapy that is very promising. Oral formulations promise greater efficacy and they are more widely available. Folks with needle fear are much more willing to be on these medications long term. And despite all of my negative predictions, I'm also anticipating and hoping that cost reduction will progress as there's wider insurance coverage for these medications and the indications broaden. The global impact of these drugs is undeniable. I know I mentioned 50 billion by 2030. I don't have the data here, but another financial institution is estimating that to double within another 5 years to over $100 billion by 2035, pharmacological weight loss medications. with any luck, we'll also see the greater adoption and acceptance of these medications being offered to folks who might not have as good of access to care, as obviously folks from lower socioeconomic strata are disproportionately affected by obesity. So, sorry, I know that was a bit of a whirlwind about a lot of the medications. I think it's unavoidable and perhaps the most important thing, but we also need to talk about the other adjunctive interventional procedures, not least of which the surgeries that we do. But there is a burgeoning number of endoscopic therapies, which are still considered adjunctive, but some of them are becoming more widely adopted as index procedures. I'll go over these quickly, but you can put a balloon in the stomach that essentially causes early satiety. There's some documentation of up to 15% weight loss at 6 months. The balloon does have to come out, so there's relapse unless these patients have established good habits and support while doing that. It costs about 10 grand. Endoscopic sleeve gastroplasty is something that is becoming a little bit more commonly adopted. It is not a technically simple procedure, but it's pretty effective and mimics the effects of a sleeve gastrectomy. It's a little bit more costly. And then there's something interesting called aspiration therapy, where essentially a peg tube is used to aspirate contents from the stomach. It's not cheap, it's not terribly effective, and it's obviously a very temporary solution. Transoral outlet reduction is just an adjunctive therapy for folks who have had bariatric surgery. We're running a little short on time, so I'm just going to breeze through these because I don't think anyone in the room except for perhaps Dr. Shermer and Dr. Shin are really advanced upper endoscopists. But again, the intragastric balloon is exactly what it sounds like, a balloon that makes you feel full quickly. It does have to come out and folks often regain the weight. The endoscopic sleeve gastroplasty is essentially an over-the-scope suturing of the greater curvature of the stomach to imbricate it and decrease the stomach volume by up to 70 to 80%. It does cause early satiety, and there is some question as to whether or not it causes any changes in the gut hormones that regulate hunger, but at the same time, that residual stomach is still there. So the loss of those gastric mucosal cells does not occur like it would in sleeve gastrectomy. The benefit of this is that folks go home the same day and they usually are back on their feet in a day or two, but it is highly operator independent, or highly operator dependent, excuse me. This is a little wild. I think I just included it initially out of curiosity. Basically, if folks get a peg tube, they inject saline into their stomach, they flush everything out and suck it out. And the idea is behavioral reinforcement, but this is not widely adopted. TORI is just an adjunctive therapy for folks who have had gastric bypass and their gastrojejunostomy and anastomosis has gotten a little bit too big and they have rapid gastric emptying. The idea is just to close down that anastomosis enough that you can restore the early satiety signaling and keep folks from eating so quickly. These are remarkably appealing to patients for a variety of reasons. Obviously, they're not surgery, there are no incisions, they go home, the risk profile is lower. And I think something that's a source of comfort for a lot of patients who are understandably hesitant about bariatric surgery is a lot of these are reversible or adjustable at least. They're also cheaper. Another added benefit is they can use in folks who might not be the greatest candidates for general endotracheal or for general surgery and pneumoperitoneum. So even though we are bariatric surgeries, and this is what we do day in and day out, this is perhaps the shortest part of the case because it's just a refresher. I know most of you are familiar with this. But the tools we currently have in our arsenal are primarily sleeve gastrectomy, Roux-en-Y gastric bypass, and two different versions of the duodenal switch. Sleeve gastrectomy is rapidly becoming one of the most commonly performed surgeries in the world. Over 150,000 of these are performed yearly in the United States. It accounts for closer to 70% of all bariatric surgeries now. And to put that in perspective, about 1 million hernias are done yearly in this country, and 300,000 appendices are taken out in this country. So it's very common. The sleeve works great, 25 to 30% weight loss. Short pitfalls include GERD and leaks, which are a big deal. Roux-en-Y gastric bypass, a little bit more aggressive, 30 to 35% of weight loss. The most dreaded complications are the chronic short and early and late dumping syndromes, marginal ulcers, and internal hernias. And then the duodenal switch, or SADI, which we are performing in increasing numbers here at UVA, is perhaps the most aggressive, and it's malabsorptive and metabolic effect. It has all the same complications of Roux-en-Y gastric bypass, save the marginal ulcers, but it does have the highest likelihood of nutritional deficiencies and malabsorption. So those of you who've been on service may or may not have seen some of these. When I came in August, I don't think we did any for a few months, but doctors Shin, Howell, and Carter have been doing these in increasing numbers. And essentially, the SADI and the duodenal switch both include a sleeve. They both include a duodenal ileostomy, which is an anastomosis, the duodenum justice pylorus. But the SADI is in a loop configuration, and the duodenal switch is in a root-like configuration. So the crux of the argument for surgery is often cost. Approximately $15,000 to $30,000 without insurance, on average about $20,000. Most insurance cover these, and historically, general surgeons and more now, bariatric trained surgeons go on to perform these operations. So how do we assess the cost effectiveness? The best metric that we can use to compare directly to medications are the quality adjusted life years. This does provide an excellent argument for surgery. In addition to the other effects, which include the resolution of comorbidities like type 2 diabetes, sleep apnea, and hypertension. And folks after these operations, if they lose the amount of weight that we expect, their mobility improves and their quality of life drastically improves. When it comes down to the numbers, we typically just say 5 years of the medications. Theoretically, these folks need to be on them lifelong or until they reach a weight loss goal. But the cost is pretty exorbitant. I'm sure that will change as these come off the patent, but it's upwards of $60,000 to $90,000 a year. Again, the bariatric surgery up front is about 20. Neither of those values take into account physician office visits, labs, and things like that. But to be put in the simplest of terms, bariatric surgery typically is about $5,700 per quality adjusted life year, 1 year of perfect quality life, whereas the GLP-1 therapies are upwards of $33,000. Obviously, as we continue to gather data on the long-term effects of these drugs, those numbers will shift. This is just side-by-side comparison. Sorry, I didn't import quite properly. Basically showing that surgery, most weight loss, most durable solution, highest likelihood of diabetes remission, if not cure, and lowest cost. But these medications, they're coming for us. So where do we fit into all of this beyond what we've already discussed? I think for now, this is still firmly a surgical disease. If and when these medications become more durable, effective, and cheaper, that might not be the case, but until that time, I think it's very important that we understand the full continuum of therapy options available to patients. Procedural expertise, knowing how to do these and manage the complications is really insufficient. And I think we should be leaders in the multidisciplinary management of obesity. And it's very important that we collaborate with obesity medicine specialists and really start to develop new multidisciplinary treatment models. I can think of it as akin to the tumor board model. Bariatric surgery is really unique to other types of surgery in the sense that it's probably the only kind of surgery where we let patients choose, they weigh in. And it's also one of the few types of surgery where we make pretty important decisions based on a very outdated and insufficient metric, which is BMI. BMI does not at all account for the phenotype of obesity, whether or not male, female, age, comorbidities, extent of metabolic syndrome, whether or not it's visceral adiposity versus extremities. And frankly, it's insufficient. So I'm hoping that with the data coming forward with all of these medications, and as we continue to collect long-term data on the outcomes of these operations, we can shift more to a cancer type approach in the sense that we develop better clinical tools to risk stratify these people and really define their obesity phenotype and give them a more tailored therapy rather than just saying your BMI is 50, you've got some diabetes, let's do a bypass. So in closing, again, it's just very important that we try to stay abreast of these changes, even if you are not a bariatric surgeon, because all of your patients will be, almost all of your patients will be involved with either these medications or procedures in one way, shape, or another. And obviously the patients only stand to benefit if we continue to work in this multidisciplinary fashion. Now, before I open it up for discussion and questions, I just wanted to take advantage of my time on the podium here to say thank you to everyone here. This is obviously just a one-year fellowship, but it's been a remarkably impactful year for me. I have to thank my mentors, the Orange Surgery attendings, Dr. Shermer, Dr. Howell, Dr. Shin, Dr. Carter, Dr. Yang, and then the entire department. And perhaps most importantly, I want to say thank you to the residents. And some of you may or may not have been at that graduation ceremony the other night. But I was and continue to be blown away at how welcoming you guys have been. Essentially an outsider, and I come in and amazed at how much you guys were willing to let me feel things out, get comfortable in an attending role on the EGS service. I know a lot of you, we had some hectic weeks back in the fall where things got a little hairy. So I'm grateful for your patience and your support in that matter. And those of you who are present at the graduation dinner, you already heard me say this, but I think you all have a lot to be proud of. This is a really impressive institution, a really awesome training program. I think you guys should be very proud of what you have here. And a part of me wishes that I had an opportunity to train here. But I think that even though I was only here for 1 year, I think I'm a Wahoo for good now. You see, Dr. Hallowell gave my family some tickets to some basketball games. I have unfulfilled hoop dreams. So that was a nice experience. My little boy learned to walk in front of the rotunda. Dr. Shermer got us swagged out in a bunch of UVA gear. Here we are. These are all compliments of Dr. Shermer. We experienced our first and hopefully only winter in our lives. Is Miami, folks. We didn't have a sled, so I just put my little boy in that little jumpsuit, and we just threw him down the side of that hill by the rotunda. Anyway, I'd love to open it up to any questions or discussion. Thank you so much for your time.
Well, let me start. It's been a real pleasure to have you with us this year. You've been a great colleague, and you've done a wonderful job of taking care of the patients and pitching in and doing the workload that fell on you because I wasn't around that much. And so I really appreciate that personally. I know you're going to have great success in Miami. You're going back to a place that you're familiar with. You've got some great mentors and support people, Steve Unger in particular, and we wish you the best of luck there. My main comment on your talk is that, a lot of the bariatric surgeons that I know are very worried we're going to go out of business. Well, the way I look at it, 7 or 8 years ago, obesity wasn't even on the radar of primary care doctors. They couldn't treat it. They told people to go on a diet, and it didn't work. And so they ignored it. They treated the diabetes, they treated the hypertension. They could fix those or help fix them. They couldn't fix the obesity. Now there is a medication to treat it, and they're thinking about it. They're actually thinking about it as a disease. And so if only 10% of the patients that they see have obesity, they refer for surgery, that's still 10 times more than the number we're doing now, because we only operate on 1% of the eligible people in the U.S. annually. So if they were to send us all the patients with obesity, we would be operating until midnight every day. There's no way we could do it. But I'm just saying, I think that right now there's a definite swing toward medications. They are going to have their role, and the integration between integrations and surgery has not really met its final process. But I think that the fact that people are just thinking about obesity as a disease is a big step forward in its treatment, and it's not going away. It's just as I mentioned in M&M this morning, 2 of the 3 first 2 cases, obesity was a huge factor in the patient's outcome. So this is a disease we have to embrace, we have to treat, and it's tough, it's prevalent, but now we have better tools for it, and that's just great.
Yeah, I think that was an excellent talk. In my mind, patients are looking for one-stop shopping. They're not interested in seeing, multiple providers to attack this. And so I think it'd be good for people that are specializing in bariatric type procedures to consider getting certification in bariatric medicine. And there is a pathway for that. I was at the American Diabetes Association meeting recently, and you can do all of this online, and it's all laid out. And so rather than having to depend on other people, you're either going to have a bariatric medicine person or persons incorporated into your bariatric surgery center, or more simply, just become bariatric medicine certified as a surgeon and then prescribe the medicines. And it sounds a bit out there, but I think it's important in the future to consider that as part of your surgical certification pathway.
Right, I completely agree. And on the level, coming into this fellowship training year, my initial thinking was, I'm going to get my obesity medicine certification. And then, like many things, life gets in the way. And I thought, man, I need to just focus on being a safe efficacious and high volume surgeon when I get into practice. I haven't ruled it out in the future. But the short reflection on your statements is that, yes, that would be ideal. And whether or not that is bariatric surgeons who are well versed and certified in obesity medicine, or someone else, it has to be someone driving the ship. Because like you said, realistically, these patients are a very difficult patient population. They're not going to go around and see 6 different people. So there has to be one person driving the ship and putting together the input and feedback from these other specialties. But short response is completely agree. And I think that is the direction we're headed if we want to have optimal outcomes. Dr. Norbench.
First, excellent talk. It was great. Really interesting talk. Second, I just wanted to thank you as a representative of our trauma service for all that you did and helping us out on the EGS service. You did quite a bit of work on that service and provided excellent care for the patients. And I distinctly remember coming in and popping in for a case that you were doing. There was a posterior perforated ulcer that, I was struck by your level of maturity and your intraoperative decision making and just everything about that room as you were leading that room and taking care of that patient just struck me as somebody who really knew what they were doing and was, had developed the maturity of somebody who had been doing this for many, many years. And to the point where certainly I had no role in that and I was not needed. So it was really nice to, pop into a room and see somebody who was so already adept at that stage. And that was early in your year. So you're going to do great.
Thank you so much. I appreciate it. Dr. Field?
I have a question, maybe advice, and despite what Bruce just said, which may be true, we saw this with cardiac surgery at some point. Nobody wanted to be a cardiac surgeon. Now, cardiac's hot again. So there's going to be ups and downs, but there is a current market, right? So if like the MIS bariatric fellowship has always been a little bit of an odd fellowship because, if you do colorectal, you do cardiac, whatever, you kind of know whatever program you're going to go to, it's roughly going to be the same training program. But for bariatrics MIS, like you can go to one institution and focus on this, and this institution focuses on that, et cetera, et cetera. But and you had a job, so you came, you knew you had a job. But what is on the open market out there when people go and do their fellowships? I do have the sense that perhaps it's not the easiest job to get right now. And so what is the market for a graduating fellow? And if you're going to advise somebody to do an MIS bariatric, do you advise them to do one that's a little less bariatric heavy and maybe, other stuff so that you've got other tools in your toolbox so you're not outdated before, yes, it might come back in 20 years, but you got your window, right?
Yeah, that's a great question and something that weighed heavily on my mind during the application process.
Yeah.
I think fortunately now I have the benefit of hindsight and this year's experience to have a pretty well-informed answer for you. But the prevailing sentiment is that there is some debate as to whether or not an MIS year is a value add. And I think that is in large part because of the heterogeneity of these training programs. I mean, it's remarkable. Just obviously not having experienced any of them, but having interviewed at multiple, like you said, the area of focus, the modality, and the diversity of cases is incredibly variable. Fortunately, as an aside, I'll say for myself that this has been, like I said, really a remarkably valuable year and definite value add. And I've told potential interviewers that I would do it again, 110%, even though I, uprooted my family and came here with no support in the area. But I do think there is utility in broadening the toolkit, so to speak. And I talk about this a lot with Dr. Carter. Let's say it does go away in its entirety, got to know how to do other stuff. And I can say, fortunately for myself, that's certainly been the case here, as we've done a ton of abdominal reconstruction and foregut cases. And I'm under no illusions, and I think most of my colleagues who are doing this fellowship are under no illusions that we're general surgeons. I mean, this is a fancy term, advanced gastrointestinal, but it's just a bunch of alphabet soup to say that we like to do certain types of procedures in bariatrics, but we're general surgeons at the end of the day, and I take a lot of pride in that. And I apologize if I'm rambling a little bit, but short answer to your question is, I do think the training is a value add. I do think that it will continue to be consolidated into a more and more focused skill set. It's always just been a big umbrella, but we're now starting to see other fellowships crop up, like abdominal wall reconstruction, which has never been a thing until now, essentially. So you will see folks with specific bariatric training. I'm very grateful that I did not go to a program with just bariatric training. And the final and perhaps most succinct answer to your question is the job market. It's non-existent. You would be hard pressed to find a job posting for a bariatric surgeon. And this is just anecdote, and I think so as a surgeon, we're all a little bit susceptible to anecdote, but if you're encountering a group that needs help and they do bariatric surgery, it's because someone's either retiring, moving along, and if they're relinquishing bariatric volume, someone is waiting to absorb it for a variety of reasons that are beyond the scope of our discussion today. But the market is bleak despite the overwhelming demand. As to how they will evolve in tandem together, I don't really know, but I'm confident and feel grateful for the fact that we do a lot of other really cool stuff. And I do think that even with the medications coming along as they have, there's going to be a lot of recidivism. Perhaps that isn't the most appropriate word, a lot of relapse, a lot of folks who can't tolerate these medications or avoid them long term. And the exposure, like Dr. Shermer was saying, pushes them towards bariatric surgery. So I do think the volume will rebound. Not, of course, not ruling out the probability of these medications continuing to be better, safer, more effective, and maybe eventually one day this does become a medical disease. But I don't think that's any time in the near future.
Can I comment on that for a second?
Yes.
Sorry. Well, firstly, Paul, you've been my partner in crime this year. Love you. You're great.
Thank you.
But to Dr. Friel's point, I just want to comment. Because I think the best way to honor the great talk that you just presented was for our medical students and our junior residents to acknowledge that the landscape of obesity is definitely changing, but that doesn't mean bariatric surgery is dead. If anything, is anybody Vinovich here? No, sorry, Emily. She has done great work. We've done from UVA, we've done Markov analyses demonstrating the cost effectiveness of provisional bariatrics in patients who had a previous bariatric surgery with refractory diabetes. Is tirzepatide more effective for revisional bariatrics? The answer at 5 years is yes, surgery is still more cost effective. The other thing that you guys should know is when you're on EGS, or not EGS, sorry, when you're studying for your test, not EGS, these RCTs that argue for 20%, 25% weight loss on these medications, that's not real world. Okay? Emily has published really nice data demonstrating that real world compliance to these medications is far from that at all. So the effectiveness of these medications is nowhere near what's advertised. The landscape will change where things will consolidate. Like Dr. Raymond said, it's centers like UVA that will outlive this transition. We have multidisciplinary weight management center that is run by medical obesity specialists and surgeons hand in hand. And those are the centers where bariatrics will continue to live. And it's on us to inspire the younger generation to join us because we need a seat at the table. We need to not be a reactionary. I have arguments with Phil Shower about this at ASM here, but it's not about responding to market trends. We have to be part of the market trend. We have to have a seat at the table to discuss the role of surgery within the landscape of medical obesity and health. That's how we're going to learn how to coexist with our colleagues in endocrine and really help our patients with obesity because, as you've heard, the prevalence of obesity is only growing in number.
Well, Paul, thank you so much. It was an amazing overview. It's been great to know you. I'm glad that you felt that this place is a home for you. Obviously, not only have you taken great care of our patients, but just from the fact that our residents, selected you as the fellow of the year that was most focused on their education. That's a huge honor. Wish you a lot of luck in Miami, and I'm sure we're gonna continue being in touch. So thank you so much.
Thank you.
I'm kind of trying to get back on the train with everything in terms of robotics. We can listen. Remind me again when that is. And yeah, I was gonna say it's like kind of July. Okay.
Next week, you might be on already.
Thank you.
Yeah. I have some serious work to do to start finalizing a schedule. The biggest thing I'm on is like
All right, buddy, how are you?
Okay, but that, hopefully I get some information, like, say. He'd like, sure, when, that's always.
So, I guess after the first year then? Or versus like what graduation gift for the Chiefs?
Well, this year, most of the Chiefs.
But this, no, Brett, what do you think, better at a Chief or like?
Maybe it would be better.
Yeah, like that would be a great graduation gift, like I say, like,
Yeah.
this is from Dr. Shermer, like every single year.
But-
But I'll support, I'll
I
pay
mean,
for
right
it.
now, most of the fourth years are. It'll be 5 years before so I don't know. So I'm just thinking.
Yeah, okay.
Think about it.
Either way,
Whatever you think might be a good, but, I'm just saying, I got plenty, and I can order.
Yeah.
I mean, not just this, and it's not, the bulk price I can order, it's like.
It's a weird, I do think
It's a good idea and, yeah. So with the Harvard, we could definitely support
You go to
that.
Wake and you go here, you go there, it's like a totally different.
So we've got Mr. Jarrell, diagnostic lab. He was doing okay right
Still
now.
vomiting or?
So he hasn't been vomiting most recently, but on early post-op he did quite a
Yeah.
bit. So I wanted to make sure that he like tolerated at least breakfast, if not lunch. But I think he can still today.
Okay.
And
You feeling better?
he's feeling better right now. I just want him to prove himself. a little bit.
Okay.
And then for Mr. Copeland, so PT and OT really like stood their ground and said like home health. So my thought is that, we could send them
With TPN?
Yeah, we'll send them home with TPN. Caitlin was talking with case management about, we could still apply for him to go to a rehab. I'm a little bit pessimistic.
Is the family okay with home?
I think they're looking for our guidance personally.
Something you should do.